Hi, Dr. Brian Kaufman, a retired family doctor, CLL patient myself, and the co-founder, executive vice president, chief medical officer at the nonprofit CLL Society here at ASH 2024.
I'm Paul Hampel. I'm a assistant professor of medicine at Mayo Clinic in Rochester, where I specialize in the care for patients with CLL and other lymphoid malignancies, with a research interest in CLL and Richter transformation as well.
Dr. Hampel, we've seen tremendous changes in how CLL is treated. And one of the biggest changes was using these BTK, Bruton tyrosine kinase inhibitors, frontline and treatment-naive patients for the majority of patients now. Mostly the first generation, the second generation, which are bind covalently, ibrutinib, acalabrutinib, and zanubrutinib. But all of these therapies are palliative, and essentially all patients at some point need another treatment. Sometimes it's a decade down the line, but more often it's shorter than that, but sometimes it's excellent. And Venetoclax is usually the go-to drug for that. And there's different paradigms that will be looked at, but that's beyond the scope of what we're going to talk about now. But you've looked at just how effective Venetoclax is in these people who used it frontline, what we call treatment naive. Their first treatment was a BTK inhibitor. Now they're going on Venetoclax we know is a great drug, but tell us what you found, how you did this study, what was going on, why was it important, what patients should take away from it.
Absolutely. So as you said, Bruton tyrosine kinase, BTK inhibitors, and Venetoclax kind of the two main options. Whichever you got first, you're likely getting the second one second,
right,
or vice versa. The drugs were developed in parallel, more or less, and so lots of the pivotal studies for either did not have patients who were previously treated with
they were developed in close sequence.
Yeah. So the data for let's just say that the pivotal study for relapse refractory treatment of relapse refractory CLL, the Murano study had essentially no patients with BTK inhibitor treated.
They were all chemoimmunotherapy.
All chemoimmunotherapy. And the median progression-free survival, how long people lived or had until their disease came back or they died, was 57 months with Venetoclax.
Impressive, yeah, impressive.
So keep that number in mind, and then even in high risk patients with high risk features of their CLL, so we'll say deletion of 17p, for example, the median in that subgroup in Murano for progression-free survival was 37 months. So keep these numbers in mind. So then the only prospective study that we had for a long time with Venetoclax after a BTK inhibitor, and in this case it was all ibrutinib, was a monotherapy study that's now over 5 years old. Monotherapy meaning they took just Venetoclax. Often people are thinking of this with the infusional immunotherapy
right,
component.
and they're thinking of it as a limited duration therapy, which is the way it's mostly used
and
today.
That's how it was studied in the Murano, Venetoclax plus an anti-CD20 monoclonal antibody called rituximab. So in this study, they're on Venetoclax on its own indefinitely until toxicity or disease progression, and amongst patients who had who had resistance, a CLL that was resistant to prior covalent BTK inhibitor, and ibrutinib essentially, the median progression-free survival was only 22 months, so under 2 years. And essentially all of those patients were more heavily pretreated and had prior chemotherapy. But over the last year or so, multiple groups, including our own, have looked at what are the outcomes in real-world setting with Venetoclax-based regimens, either Venetoclax on its own or with obinutuzumab, a different infusion that we think may be better, or rituximab in a post-BTKi setting, and specifically exposed, meaning they'd been treated and stopped for a reason other than disease progression, or with resistant CLL, meaning that the disease had grown on covalent BTK inhibitor. And across our study from Mayo Clinic, or from the Australians, the Peter Mac group, the French, or Eric, I think, had
The
poster
European
as well.
Research
Yep,
Initiative in CLL,
last EHA. Across all of these, you're seeing a similar, this 2-year mark continues to show up, somewhere in this kind of 2 to 3 year range, but sometimes shorter in the setting of the Australians. But across all of these studies, it was still predominantly including cohorts of patients that had received chemo or chemoimmunotherapy and amongst multiple lines of therapy and had received a BTK inhibitor and then received Venetoclax. So it was different than perhaps what we expect to see from treatment history in patients that we're seeing in clinic now, as chemoimmunotherapy has, exited from the treatment paradigm contemporarily.
God willing, it's not completely gone yet. We
Yeah.
still have some work to do.
Yeah.
Yes.
So those were very sobering numbers. I mean, that was very disappointing to see, though, because we still do have patients who have received chemotherapy and then had a very durable remission in a second line or third line setting with covalent BTK inhibitor. And I think clinicians and patients were thinking, okay, chemo didn't work very well for me, but I got this targeted drug and it worked well for a very long time. And unfortunately now the disease is starting to progress, but you've got another one of these great targeted, and everyone kind of had the mindset, okay, we're going to get something similar, maybe not the same. You get kind of some diminishing returns with later lines of therapy, but you had another kind of home run hitter taking swings in the on-deck circle that was going to be able to give another very durable remission. And what all of these studies showed is that, for how much we debate, which CD20, or do you continue it beyond 2 years, or do you do 1 or 2?
Right.
The sobering effects of the data was that half of patients were having their disease progress, essentially on the therapy or before, right around that 2-year mark. So that's what led to the current study, which was a collaboration between patients seen at Mayo Clinic and 8 centers across France, where we looked at patients who were receiving Venetoclax-based treatment after prior covalent BTK inhibitor, ibrutinib, acalabrutinib, or zanubrutinib, and no prior chemotherapy.
So a unique group, yeah.
Yeah, a really an area that's lacking data for sure. And so most of these patients were then receiving Venetoclax in a second-line setting after first-line covalent BTK inhibitor. And what we found was that amongst patients so there was 85 patients, still relatively small cohort, so that's a caveat to keep in mind here, but there were 39 patients who had BTKi resistant disease, meaning the disease grew on covalent BTK inhibitor, and then the remainder that were exposed. Had been treated, had received BTK, but did not have disease progression, stopped for some other reason.
Right,
toxicity.
usually intolerance, yeah.
For those patients, they did fantastic. The median time to next therapy or death, TTNTD, which I'll explain in a second, was 6.5 years. So what does this mean? It's actually, I think, a bit more of a clinically relevant endpoint, in so much as people can have disease progression by our criteria, but still not need therapy for a long time. So this was how long from the time that they started therapy until they needed another therapy or died for any cause. So that looks pretty much similar to the CLL14 study.
Maybe even a touch better.
Yeah, it basically, lots of caveats, but basically, if you're receiving this as in that setting, you can expect to do very, very well as patients who are receiving it as their first therapy, more or less. Fortunately, for the 39 patients who had disease progression on a covalent BTKi inhibitor, that was not the case. And for those patients, it was again, the median TTNTD, or time to next therapy or death, was again in between 2 and 3 years. And so that's alarming. But I think an important thing is to then still look one step upstream and say, well, what are the characteristics of these patients, and also what was how did their course go on the covalent BTK inhibitor? And I think that explains some of this story. So sure, this cohort was enriched for patients with high-risk features that we know of the disease, unmutated IGHV, karyotypic complexity, complex karyotype, and TP53 disruptions. But I still don't think that adequately captures, why they're doing so poorly. Because again, even in the Murano study, if you look at just the subgroup who had del(17p) CLL,
Right.
the median PFS was 37 months. So I think there's a potential new kind of high-risk feature, so to speak, or characteristic, which is the median time for these patients to derive benefit from their covalent BTK inhibitor was a little under 4 years. That's way short. I mean, we talked about, I think long-term follow-up from Resonate-2 is kind of the median's kind of coasting in around 9 years, but patients for sure, even in the setting of del(17p, get longer, 6.5 years on average from the NIH data. So that's a very short initial PFS1 or time of benefit from their
Progression-free survival.
Yeah.
Yeah.
For their covalent BTK inhibitor. So I think the way that I'm looking at this is not to sound the alarms and everyone that's on a BTK inhibitor to think that the sky is falling when the disease starts to come back, that they're going to be in a rough shape. It's that if I'm seeing somebody in clinic who's coming in and their disease is progressing after a much shorter than expected time on their first line BTK inhibitor, then I really am needing to think, okay, maybe this, I mean, of course we always want to say a well-designed clinical trial is a great option, and we're trying to think of good trials, but I think especially in that person, there's someone who's going to benefit from novel therapeutic strategies to try and improve upon a status quo, because I'm going to have a particularly high sense of urgency to improve status quo. So be that a ven-based combination otherwise, or thinking of sequencing even beyond that. How I think you just need to be a little bit more forward-thinking in your planning for a patient who's had a short duration of benefit on their covalent BTK inhibitor, and now you're looking at ven-based therapy.
Yeah, and Ven, we need Venetoclax here, but I think the takeaway for this is when patients look at these reports, and patients do, you got to make sure you're in that group. If you took a BTK inhibitor and got 8 years out of it and then progressed, that's not who you're talking about here.
Yeah, I don't know, we don't have those patients, but my gestalt is that they're not going to have this poor of outcomes with it. If you had your first line BTK and you were on it for 8 years and now you're getting something else, it might not still be as good as we'd like it to be, and there might be some middle ground here, but I have to assume it's going to be better than this, where...
And that's what I'm saying. When you look at a trial, make sure you're you would be one of the people that they're talking about in that trial, because you got to compare apples to apples.
Yeah.
Any final thoughts on this kind of research and implications for patients?
Yeah, I think this type of research, this collaboration, having well annotated databases and being able to look at some of this real world data before we're able to get answers from prospective studies. Of course, this is hypothesis generating. It's not telling us exactly what to do, but it still highlights for all the advances that we're having, and those are much to be celebrated. There's still some high-risk patients where we need to be innovative, not just in second-line setting, but even in the first-line setting, where there are patients that we can do better for. The bar is not so high that we can all sit back and say, our work is done here. There's still work to be done, and fortunately, there's passionate people like yourself and myself and others that are working towards this end.
Yeah, CLL is not a solved problem. We've made tremendous progress, but it's not a solved problem. But thank you for your help trying to solve it. So appreciate it. Thank you.
My privilege being here.